Welcome to the Deep Dive, the place where we take your source material, crack it open, and really pull out the high-yield knowledge you need, fast. No wading through dense text, just the core stuff delivered right to you. Today we're diving into vaginal candidiasis, probably better known as a vaginal yeast infection. We've got a really focused set of revision notes here, perfect if you need a targeted review on this condition. So our mission really is to unpack these notes together, point out what's crucial for understanding, and importantly, for recall. We want to give you that solid overview based only on what's in this source. Think of it as your shortcut to getting up to speed on vaginal candidiasis, just from these notes.
Exactly. And it's such a common condition, isn't it? So understanding it clearly is definitely high yield, whether you're revising or just want to know more. These notes cover the essentials, and we'll make sure we hit all the key points.
Okay, let's jump right in then. According to these specific notes, what exactly is vaginal candidiasis?
So the definition here is pretty straightforward. It's a common fungal infection affecting the vagina and the vulva. The notes clearly state it's caused by an overgrowth of the fungus Candida.
Okay.
And Candidaalbicans is singled out as the main species responsible. And the key symptoms listed, the things people notice, are itching, a burning sensation, that sort of abnormal discharge, and just general discomfort down there.
Got it. Fungal overgrowth causing those classic uncomfortable symptoms. Okay, before we get into the why and how common are we talking here?
Yeah.
Why is it worth focusing on these notes?
Well, the epidemiology section really drives this home. It's globally very common. The notes say most women will actually have at least one episode. And while they mention specific UK data is a bit scarce in this source material, globally the figure given is significant. 70% of women experience candidal vulvovaginitis at some point.
70%. Wow.
Yeah. And maybe even more important for revision purposes, recurrent infection, and the notes define this clearly as 4 or more episodes a year that affects 8% of women.
4 more, okay.
And here's something interesting. 10% of women apparently have asymptomatic colonization. So the fungus is there, but no symptoms.
Right, just hanging out.
Pretty much. And more broadly, Candida species are carried asymptomatically by about 60% of healthy people in various places on the body. The notes also highlight a peak age for getting symptomatic infections. That's between 20 and 40 years old.
Okay, 70% experiencing it, peak age 20, 40. And that asymptomatic point is fascinating. It definitely makes this a high-yield topic, especially if you're seeing patients in that age group. So we know it's an overgrowth of Candida, usually see albicans. The notes then go into etiology and pathophysiology, basically. What kicks off this overgrowth, and how does it actually cause symptoms? Let's unpack that bit.
Right. So the etiology, the causes, the notes list several contributing factors. Hormonal changes are a big one.
Like pregnancy?
Exactly. Pregnancy is listed, but also things like oral contraceptives or hormone replacement therapy. Then there's a weakened immune system. Uncontrolled diabetes is a classic risk, and medication use.
Antibiotics often get blamed, right?
Yes. Broad-spectrum antibiotics are specifically mentioned. They're key because they can kill off the beneficial bacteria in the vagina, the ones that normally keep Candida levels down, so it disrupts that whole vaginal microbiome balance. And while C. albicans is the main player, the notes say 85–90% of cases, it's good to remember for revision that other species can cause it too. They list C. glabrata, C. tropicalis, C. cruceae, C. parapsilosis.
Okay.
And there's even a mention of C. auris as an emerging resistant species to be aware of. Then the pathophysiology, the how, it's basically that overgrowth disrupting the normal balance of microorganisms. This disruption can be triggered by pH changes, those hormonal shifts we mentioned, or a weakened immune response. But the notes add another layer under pathogenesis. It suggests symptomatic infection isn't just about the amount of fungus. It might also involve a hypersensitivity reaction from the person's own body.
A hypersensitivity, like an allergic type reaction.
Sort of, yeah. The body's own immune response might be overreacting to the Candida, and genetics and estrogen levels could influence that response, contributing to the symptoms people feel.
That's really interesting. So it's not just the fungus itself, but potentially how our own body reacts to it.
Yeah.
All within that disrupted environment. That definitely adds complexity. Okay, building on those causes, what specific risk factors do the notes highlight? What puts someone at higher risk for this overgrowth turning into an actual infection?
Yeah, the notes give a pretty detailed list. It helps to group them mentally, I think.
Good idea.
So first, you've got medical conditions. Pregnancy is a big one, as we said. Uncontrolled diabetes is right up there. Anything weakening the immune system like HIV, or medications like immunosuppressants, chemotherapy, corticosteroids. Cushing's disease, cancer, malnutrition are also mentioned as general risks for candidal infection.
Okay, medical conditions make sense.
Then medications, which links back to the causes. Broad-spectrum antibiotics, definitely. Oral contraceptives and hormonal therapy pop up again because of the hormone link. And then there are behavioral or local factors, things like frequent douching that can mess up the natural balance. A history of previous infections makes you more prone. Local conditions matter too, like heat, moisture, skin getting broken down or macerated, using topical corticosteroids in the area, or having underlying skin issues like psoriasis or dermatitis there. The notes mention poor dental hygiene for oral thrush, but the principle of local environment being important applies generally. Extremes of age are also listed as a general risk for candidal infections overall.
Okay, lots of local factors.
And finally, the notes list some medical procedures or devices as general risk factors for candidal infections. Maybe less directly tied to vaginal unless they impact overall health, things like central lines, implants, radiotherapy, GI surgery.
That's a very comprehensive list from the notes. It really paints a picture of that perfect storm idea, multiple factors coming together.
Right.
Linking these back to the causes disrupting the microbiome, changing hormones, lowering immunity really helps it stick.
Right, so we've covered what it is, the mechanics behind it, and who's more likely to get it according to these notes. Now, the clinical picture. What does it actually look like? What symptoms would someone have, or what signs would a clinician find? The notes are quite specific on the clinical features. The main things are intense itching, pruritus, and irritation of the vulva and vagina.
Itching is usually the big one, right?
Absolutely. And burning is very common too. Then there's the discharge. The notes use that classic description, cottage cheese-like, usually thick, white, maybe lumpy. And a key point for differentiation is that it's typically described as non-offensive, meaning it doesn't usually have a strong or bad odor.
Okay, that discharge description is key.
Definitely. And on examination, the notes say you might see redness and swelling of the vulva, that's vulval erythema and edema. You might also see fissuring little cracks in the skin or maybe satellite lesions, which are smaller spots spreading outwards from the main area, and excoriation signs of scratching, basically.
Makes sense if it's that itchy.
Exactly. Oh, and one more useful clinical pointer from the notes. The symptoms sometimes worsen just before a period and can actually improve during the period.
Ah, interesting timing. That cottage cheese discharge and the link to the cycle are really memorable details for revision. So how do the notes say this is usually diagnosed? Is it just based on symptoms, or do you need tests?
Well, according to these notes, diagnosis often starts with the clinical picture, the symptoms the patient describes, and what's seen on examination.
Okay.
But investigations are common. Looking at the vaginal discharge under a microscope is standard practice. You can directly see the Candida yeast cells, or hyphae.
Right, seeing is believing.
Pretty much. And a fungal culture can also be done. This involves trying to grow the fungus from a sample. It helps identify the specific Candida species involved, which is useful, the notes suggest, particularly if it's recurrent or not responding to standard treatment. Other tests might be done just to rule out other possibilities or check how severe it is. It's interesting, the notes briefly mention oral thrush diagnosis, saying that's often just clinical, and swabs aren't as routine unless you suspect resistance, maybe in someone with HIV. So that kind of highlights why microscopy and culture are perhaps more standard for the vaginal form.
That makes sense. Confirms the fungus is definitely the cause. Now, speaking of other possibilities, if someone has these symptoms, what else could it be? What's on the differential diagnosis list in these notes?
This is a really crucial part of the notes because, as you can imagine, symptoms like itching and discharge can point to several things. The list of differentials is quite long.
Okay, let's hear it.
So other infections are a big category. Bacterial vaginosis, or BV, is a common one. Trichomonas vaginalis is another potential cause. And the notes really stress considering sexually transmitted infections, STIs more broadly.
Right. Important not to miss those.
Definitely. Then you've got non-infectious causes.
Okay.
Atrophic vaginitis, that thinning and dryness often seen after menopause due to low estrogen, can cause similar irritation. Skin conditions affecting the vulva are also listed. Lichen sclerosis, contact dermatitis, which should make you ask about new soaps, detergents, things like that. Eczema and psoriasis can also affect that area.
Okay, skin stuff too.
Yeah. And mechanical irritation gets a mention, things like intense cycling, or sadly, it can be a sign looked for in suspected sexual abuse in children. Less common things listed include rectovesical fistula, And importantly, urinary tract infection, UTI, is on the list, probably because symptoms like burning can overlap and the areas are so close.
Wow, that is quite a range.
Yeah.
BV, STIs, skin conditions, UTI.
Exactly. And the notes imply that telling these apart really relies on that careful clinical assessment, often backed up by the investigations like microscopy we talked about.
It really drives home why getting a proper diagnosis is key, and maybe not just reaching for an over-the-counter treatment without being sure, especially with STIs potentially in the mix. Okay, so once it's confirmed as vaginal candidiasis, what do the notes say about management? How is it treated?
Management, according to these notes, revolves around antifungal treatment. Makes sense, it's a fungus.
Right.
The options generally fall into topical treatments, creams, pessary, suppositories that you apply directly, or oral medications, pills you swallow. The notes say both local and oral routes are effective choices.
Is one better than the other?
The notes suggest that for mild cases, over-the-counter options might be sufficient. But for more severe infections, or if it keeps coming back, prescription-strength treatment is usually needed. For first-line treatment, the notes specifically recommend oral fluconazole as an option. If that can't be used for some reason, intravaginal clotrimazole is listed as another first-line choice.
Okay, fluconazole or clotrimazole?
Yes. And they add that a topical imidazole cream can be used alongside these, specifically to help with the vulval symptoms, the external itching and soreness, which can be the most bothersome part. There's a very important point for pregnant women. The notes state they should only use local topical treatments. No oral antifungals during pregnancy based on this source.
Good safety point.
Definitely. And addressing those underlying risk factors we discussed earlier, like getting diabetes under control, maybe reviewing antibiotic use that's highlighted as important for managing it long term, especially preventing recurrence. Speaking of recurrence, for those cases, remember, 4 or more episodes a year, the notes say you need to check they're actually using the treatment correctly. Reconfirm the diagnosis is definitely candidiasis, rule out those other conditions again, and possibly consider what's called an induction maintenance regimen, like a longer course of treatment.
Right, more intensive for persistent cases.
Exactly. On a positive note, the success rates mentioned are good, over 80% cure rate for acute infections with either topical or oral azole therapy. But special care is needed for severe infections or treatment failures. And finally, there's general advice. Use soap substitutes instead of harsh soaps. Keep the vulval skin moisturized. Wear loose-fitting cotton underwear. Avoid irritants like perfumes and maintain good hygiene.
It's really helpful that the notes give specific drug names like fluconazole and clotrimazole. That's key detail for revision. And the practical lifestyle tips are always good to remember. So after treatment, what's the outlook? Is it usually done and dusted, or can there be longer-term issues according to these notes?
The prognosis section suggests it's generally very good if treated effectively with antifungals. Symptoms usually get better within a few days.
Okay.
And that cure rate for uncomplicated cases is high, like we said, around 80%. In terms of complications, for most straightforward cases, it's usually self-limiting, and the notes don't list major physical complications beyond the immediate symptoms. The main complication that's emphasized is recurrent infections.
Ah, yes, the ones that keep coming back.
Exactly. And while maybe not physically dangerous for most, the notes make a point of mentioning the significant impact this can have on quality of life. They specifically mention potential links to depression and psychosexual problems for those dealing with chronic recurrence.
That's a really important aspect.
It is. Spread to other parts of the body is mentioned as rare and much more likely if someone has a severely weakened immune system. The advice is also clear. Seek medical help if symptoms don't improve or get worse despite treatment. And it notes that treatment during pregnancy might have slightly higher failure rates.
So generally good outcome, but that psychological toll of recurrence is a key takeaway from these notes, not just a trivial thing for some. And lastly, prevention. Do the notes offer much on how to prevent it in the first place?
The prevention section specifically for vaginal candidiasis in this source is actually quite brief. It mainly points towards the future, mentioning that advances in understanding how the fungus works have led to vaccine development.
Vaccines for thrush?
Yeah, apparently they're currently in clinical trials, according to these notes. So that seems to be the main preventative strategy highlighted here, something potentially on the horizon. The source does mention other prevention points for oral candidiasis, like inhaler technique, denture care, stopping smoking, but focusing on vaginal, it's mainly this vaccine point.
Okay, interesting. Vaccines would certainly change things. Right, let's do a quick high-yield recap to help lock this in for anyone revising. Key facts from these notes. Most cases caused by Candidaalbicans, super common affects up to 70% of women, peak age 2040. Remember that cottage cheese-like discharge description? Common risk factors include antibiotics and pregnancy. First-line treatments mentioned are oral fluconazole or topical clotrimazole. And that definition of recurrent is key, 4 or more episodes per year.
Absolutely. And add to that remembering the key things it could be confused with: BV, STIs, skin conditions, making diagnosis important. And the general advice on hygiene and avoiding irritants can be helpful for management. Given how incredibly common this is and how it links into the whole balance of our microbiome and immune system, and then hearing about potential future strategies like vaccines, maybe the provocative thought to leave you with from these notes is this: how might our growing understanding of the microbiome and the development of targeted approaches like vaccines against specific microbes fundamentally shift how we manage these kinds of common conditions in the future? Conditions that seem simple but clearly have complex triggers and can have a really significant impact on people's lives.
That's a great thought. We've definitely gone deep into the details of vaginal candidiasis today, extracting the core information straight from these revision notes. We really hope this deep dive helps solidify your understanding and makes recall easier.
Yeah, understanding these common conditions, getting the core concepts down, it's vital, whether you're actively revising or just aiming to be better informed.
If you did find this useful for your revision, perhaps for the MSRA, or if you want to explore more resources geared towards that, you can find information over at passthemsu.com.
And for some free resources, which often follow this kind of high-yield summary approach, you can check out freemsu.com.
Okay, that wraps up this deep dive on vaginal candidiasis. Thanks so much for joining us.